Hi, good evening, good morning, good afternoon, everybody, wherever you are. Welcome to this special webinar by the International Academy for Clinical Hematology. We are the 3rd of May, 2023. It's a little bit past 6 p.m. in Paris, past 5 p.m. in Birmingham, and it is a very, very special week, not only because of the coronation of His Majesty King Charles III, but we have also today a distinguished speaker and expert, namely Professor Charlie Craddock, who is the director of the Birmingham Center for Cellular Therapy and Transplant, the University Hospitals in Birmingham, and he's also a professor of hemato-oncology at the University of Birmingham. Professor Craddock trained in hematology at the Hammersmith Hospital in London, at the Institute of Molecular Medicine at the University of Oxford and the University of Washington in Seattle. He's the chair of the UK Stem Cell Strategic Oversight Committee and was past medical director of the Anthony Nolan Institute. He also served as president of the British Society of Hematology and drove the establishment and subsequent expansion of the Center for Clinical Hematology at the Queen Elizabeth Hospital. Among his great achievements are the leadership of the UK Hemato-Oncology Trials Acceleration Program. He also pioneered the development of a UK stem cell transplant trials network, namely the famous IMPACT network, which is driving and leading some key and transformative clinical trials. Professor Craddock has been awarded the CBE for his services to medicine and medical research in 2016, and he is on the New Year's honors. He was elected recently as a fellow of the Academy of Medical Sciences in 2020. So, Charlie, we are extremely proud and honored having you speaking tonight for the ICH. And the topic is about optimizing transplant outcomes in patients allografted for AML. So this is a live webinar and highly interactive. We'll have a live Q&A at the end of Professor Craddock's talk, so please don't hesitate to send your questions. So Charlie, the floor is yours.
Well, thank you, Mohammed, and it's a real privilege to join you. I was congratulating Mohammed on the establishment of the IACH, which I think is a great new vehicle for spreading education and interaction. I might even go so far as to say that Mohammed Moti is a latter-day William Caxton, who you remember in 1476 by inventing the printing press. His invention really underpinned the Reformation and was a transformative technological advance in spreading information, in this case, allowing free and easy access to the Bible for people for whom it was previously only within churches and completely controlled by the priest. And I think actually what Mohammed and colleagues are doing with these webinars with Zoom is very similar, because we're opening up educational and interactive opportunities for many of our colleagues who simply can't travel to get to meetings. Mostly our colleagues actually who are doing all the hard work. So I view you in that light, Mohammed, and maybe you and I might get together and write a little editorial together, perhaps about Caxton and Zoom. The other reason I'm thrilled to be talking to you today is I've just had the most interesting result from a patient who we transplanted about 6 months ago. And the reason I mention this is because I think there is a mixture between science and art in how we transplant patients. Well, but let me give you the therapeutic dilemma that we were wrestling with on our unit a few weeks ago, actually up until about 10 minutes ago. This was a patient who was 60, who had a RIC allograft, NPM1 positive AML, had MRD after 2 cycles of induction. And the transplant was uneventful. And then we did post-transplant MRD studies on day 90 at Richard Dillon's lab, and there was detectable MRD. So we were concerned about this, but wondered whether this was persistence. We ensured that the rest of his cyclosporin was tapered rapidly, and he actually did develop a limited rash and quite marked pruritus and a sore mouth. So we were concerned that this guy had NPM1 persistence, but also had some limited cutaneous GVHD, and wanted to see what the result of a repeat bone marrow aspirate was. We repeated it, and he still had presence of NPM1 transcripts fulfilling the ELN criteria for disease relapse post-transplant. So we were stuck with a man who had developed what appeared to be limited cutaneous GVHD, but looked like he had relapse disease. Should we give him DLI? Should we run the risk of severe, potentially life-threatening graft versus host disease, giving DLI so early? Our dose would be 1 × 10⁷ in the setting of a sibling allograft. And in somebody particularly who had pretty clear evidence of biopsy-proven GVHD, although it had resolved with topical steroids. Or should we sit tight? Anyway, so we harvested lymphocytes from the sibling and cryopreserved them. And then we actually just did another marrow, because I was thinking to myself, maybe if he's getting a bit of GVHD, he's getting a bit of GVL. So I saw this lovely man today in clinic, was waiting for the MRD, was worrying that it was going to still be positive. We'd have to give DLI to this guy who was getting very severe. He's going to get severe GVHD. And I just, before joining this webinar, had the result through. So he's now MRD negative. So I think that allo response that gave him some cutaneous GVHDs also had a GVL effect, and we didn't need to give him DLI. So I thought I'd share that with you. We try and have evidence-based medicine, but there are parts of transplant where consultation with colleagues and sometimes just watching and awaiting events is important. We might even discuss that patient at the end, Mohammed. But what I want to do today is talk a bit about how we improve outcomes in patients allografted for AML. But first of all, I wanted to remind you of how important an allogeneic transplant now, what a central role it has to play in the majority of adults with acute myeloid leukemia, particularly patients over the age of 50. And the reason for this is an increased recognition, just speaking back to the case I was talking about the potent anti-leukemic activity of an allograft compared with chemo, but also the fact that we can now, because of increased donor availability, decreased transplant toxicity, deliver allogeneic transplants in patients up to the age of 75, providing they're fit. Next slide, please. So let's first think about how we decide which patients should transplant, and it's something that we kind of wrestle with, isn't it, every time we have a new patient clinic? But I think the more I do it, in some ways, the easier it becomes. I think this is the seminal data that informs our decision-making process, and it comes from the Hovon group, Jan Cornelissen's beautiful study published in JCO, where he looked at overall survival, relapse-free survival, but for the purpose of this discussion, relapse risk in patients in CR1 who either went to an allograft or had continuous chemotherapy. So just look at the bottom third of that graph. What you can see is that consistently across normal cytogenetics, adverse cytogenetics, the incidence, the hazard ratio for relapse is about 0.35 in patients who are allograft. In other words, there's something like a 65, 67% reduction in relapse risk if you go to an allograft. So next slide. So that allowed the ELN to come up with these, really seminal instructions or advice or guidance about who we should consider for transplant. And my colleague Justin Loke has updated it recently to incorporate MRD data. And you'll be aware of this, but the reason I'm showing it is because I think this is an evolving area. So at the moment, the assumption is that in patients who relapse, that their risk of relapse is reduced by about 70%, 60 to 70%, if you go for a transplant. So if you have a predicted risk of relapse with chemotherapy alone of 25 or 35%, that risk after a transplant is more than halved. You can see that. And the same in a patient with a predicted risk of relapse of 70 or 80%, more than half, 30 or 40%. So that allows us then to look at patients in CR1 and say there is a risk of relapse where the reduction in relapse risk conferred by an allograft in a fit patient with a good donor more than outweighs the potential transplanted related mortality in a fit patient. And that roughly comes out at a predicted risk of relapse of, say, 40 to 45%. So obviously for patients with good risk cytogenetics who are MRD negative, say NPM1 negative, their predicted risk of relapse with chemotherapy alone is about 30%. The risk of relapse with a transplant is lower, but you wouldn't want to take them to a transplant because that risk of relapse is outbalanced by the 2-year transplant-related mortality, which in most good units is about 15%. So let's just think about the underpinning rationale for this graph. I'm sorry, somebody's just opened my door. I just have to close it. So the assumption here is that if you relapse, not having had a transplant, you're going to do very poorly. And I wanted to advance to you that the decision-making around first CR1 patients will evolve, because the assumption is that if you relapse, you're going to do very poorly, that your predicted outcome of survival with relapsed AML, I mean, the ECOG data is only about 10% long-term, and that's largely because the salvage rates for patients at the moment is only about a 40% chance of getting a second CR. So if it's possible to actually salvage more patients who relapse if just treated alone with chemotherapy, we may actually defer more transplants to a second remission. And then secondly, of course, the critical consideration is what's the toxicity of transplant? And if we can reduce the toxicity of transplant, then we will actually be prepared to contemplate allogeneic transplant in patients with a lower predicted risk of relapse. So there was 2 pieces of data at ASH I want to share with you that are highly pertinent in this context. Next slide. The first was data from the MD Anderson by Courtney Donado, which shows the CR rate in patient, the CR2 rate in patients who have relapsed, but who are salvaged with a FLAG-IDA venetoclax combination. Now, this is quite a potent combination. There's very significant neutropenia, and there was dose adjustment of the FLAG-IDA to make it tolerable. But the really interesting thing here is that in patients, you can see bottom left, with intermediate risk cytogenetics, small numbers, of course, using this combination, you can get actually quite high CR2 rates. So I'm advancing to you that we need to be thoughtful about prospective randomized studies of novel salvage regimens, because if it is possible to salvage CR1 patients who relapse and have a higher CR2 rate, then we may be postponing transplant to later. And then second, next slide, please, is how are we doing in terms of reducing transplant toxicity? Well, I think in that context, we'll come to this in a minute, we've made real progress with the advent of reduced intensity regimens. But of course, one of the real challenges still is the risk of severe graft versus host disease that contributes, and I think this is true particularly in older patients, to significant transplant morbidity and mortality. So the US CTN group have delivered the BMT CTN 1203 study, which was a randomized phase 2 3-arm study of 3 novel GVHD prophylaxis regimens. And they used innovatively a primary endpoint of 1-year graft versus host disease-free survival. They then wished to examine in a phase 3 study the benefit against the best of the BMT CTN 1203, which was a TAC methotrexate arm, the benefit of the use of post-transplant cyclophosphamide. So next slide, please. So these are the preliminary results of the BMT-CTN 1703 result presented by Shelley Holton at last year's ASH. And this is data in patients transplanting using peripheral blood stem cells from matched or mismatched unrelated donors, having a RIC regimen randomized 1-to-1 to the experimental arm, which incorporates post-transplant Cy. There's the primary endpoint. Next slide, please. And the striking observation from this study is that the 1-year GRFS was significantly superior with a post-transplant cyclophosphamide arm. Next slide. And that was consequent on a reduction in severe acute GVHD and chronic GVHD. Next slide. But without a concomitant increase in relapse. Next slide. So these data haven't yet been published, but I think the data at the late breaker in ASH was really encouraging. It builds on some very important work that Mohammed published in this area recently as well. But it looked like in the RIC setting, post-transplant Cy reduced the risk of GVHD, contributing to an improved GRFS without any significant offsetting factors. So I think we wait to see the final paper. I think the other thing is we would wait also to see the result of the MOTD trial that's being led by my colleague Ron Chakraverty through the Impact Trials Network, which is having as the control arm an ATG-based control arm, because I think that's the one criticism of BMT-CTN 1703 is it was a T-replete control arm. But it looks like, in terms of thinking about who we take to transplant, there may be progress in terms of salvage options, which may push some patients to transplant in CR2. And secondly, it also looks like we may be able to eat into the transplant toxicity and mortality. And I think this is a particular opportunity to reduce the transplant-related mortality in older patients who tolerate steroids so poorly. Next slide, please. So the other study, I thought I'd just put this really provocative data in from the outstanding German transplant group. This is data from Dr. Stellis, the ASAP trial, in which essentially they asked in patients with a poor response to induction chemotherapy or with relapse disease, was there a requirement to have salvage chemotherapy before you proceeded to transplant, or could you manage these patients just with either watchful waiting or some low-dose Ara-C before they go to transplant? So next slide. So this is the population of patients studied, broadly similar. We have, in my judgment, very limited molecular data available on this subset, and I think that's something that will be important before we can interpret this study properly. Next slide. And what they were able to show using a primary endpoint of disease-free survival at 56 days post-transplant, we might discuss whether that is a clinically relevant primary endpoint, but nonetheless, that there appeared to be equivalence between the two arms. Next slide. That in itself is interesting, but also more importantly, that the leukemia-free survival, when calculated from day 56, or the overall survival for randomization, was equivalent. Next slide. So in terms of progress, in terms of how we utilize transplant in AML, I think it is important that we're thoughtful about transplant strategies in patients with refractory AML. I published with Mohammed one of the first studies looking at the fact that in patients with formal primary refractory AML, you can in about 30% of patients get long-term disease-free survival. And I think this study is also important. Doesn't answer all the questions, but it's suggesting there may be a subpopulation of patients who don't necessarily need salvage chemotherapy, but can get a good long-term outcome after an allograft. I think if you want my judgment, we need much more data on diagnostic genetics before we can help identify which patients this may apply to. But I think we should really congratulate our German colleagues on a highly innovative and important study. Next slide, please. So now then, just to move to the heart of the talk, really, which is just to kind of slice up what are the approaches that we could take to reduce the risk of relapse, which we all know is between 30 and 60% in patients allografted for AML, depending on their cytogenetics and molecular NGS characteristics, and also, of course, their disease status. So there's a significant risk of relapse. What could we do to reduce that? So the first thing we could do, we know that pre-transplant MRD is important. We'll look at that in a minute. Well, we could do something about pre-transplant MRD. The second is maybe there's a Goldilocks conditioning regimen out there that gives you enough anti-tumor activity without significant toxicity. And then lastly, how can we optimize this graft versus tumor effect, possibly through maintenance strategies? Next slide, please. So the breaking data on the importance of pre-transplant NGS in terms of predicting risk of relapse came from a paper in JAMA about 3 weeks ago. This is from the pre-measure study led by Chris Hurrigan. And there you can see in this very large cohort of patients that pre-transplant FLT3 ITD positivity predicts an increased risk of relapse. Next slide. And this is also using NGS FLT3 ITD MRD assay, similar to the one used by Chris Hurrigan. This was a German study, a very nice study, demonstrating, again, in patients who had pre-transplant MRD positivity, increased risk of relapse. Remember, it may well be that the impact of pre-transplant MRD positivity is genotype specific. There seems to be some data that in IDH mutated patients, if you're pre-transplant MRD positive, it doesn't have such an adverse risk, but in FLT3 ITD positive patients, it certainly does. And I think this is an important area for prospective studies. Next slide. So the challenge I think you can make, and then the other reason why you might think about saying, well, look, if pre-transplant MRD is bad news, can we do something about it? The reason you might think that this is an area for us to play in is the data from Jeffrey Lancet, the pivotal CPX versus DA study in patients over 60 with adverse risk AML. The survival benefit, that's panel C, was primarily conferred in patients who had CPX and went to a transplant. There isn't MRD data in this study, sadly, but you could argue that maybe because the CPX optimize the pre-transplant MRD status. You could, on the other hand, say that there was less transplant toxicity in the CPX arm. Next slide. And the reason that this is important is because what we do when we're thinking about taking a patient to transplant, the first thing we do is give them induction chemotherapy. And induction chemotherapy has an impact on pre-transplant MRD, but it's also quite toxic. Remember, in older patients, particularly those patients with some comorbidities or adverse cytogenetics, that the death rates with intensive chemotherapy can be quite high. Look at the bottom left panel. So this is patients who were, let's look at patients 65 to 69, and patients with a couple of comorbidities. You're finding there that the day 60 treatment-related mortality can be as high as 15%. So we have to think that actually our ability to take patients to a curative transplant may be compromised by what we give when we have induction chemotherapy. And I just also wanted to flag that although CR rates in young patients with intermediate risk disease are good, in older patients with adverse risk karyotype, CR rates are running about 50%. So you can make a case that this is an area where we want to have better induction regimen. Next slide, please. In other words, if you just look at the left-hand side of the this sequential diagram, what you do with induction, what you do with consolidation may be just as important as conditioning and the other features. In other words, we should look at the induction chemotherapy as part of an integral, a holistic package, including allogeneic transplant, that taken together is curative. Next slide, please. So where might we improve induction regimens? Well, there's some quite provocative data from ASH. There's some really interesting data from Naval Dava's group in MD Anderson using magrolimab, the anti-CD47, in conjunction with venetoclax and azacitidine. And this triplet in frontline patients, next slide, please. This is patients over 75 or unfit patients, high-risk population. He was seeing in this population CR rates with CRI of 70%, which is pretty encouraging, but encouragingly high rates of CR in patients with a mutated TP53. And importantly and interestingly, the day 60 treatment-related mortality in this cohort of 50 older patients was 0%. Next slide. So in the UK, the next UK intensive study called ACT-AML 101, we're going to be randomizing patients with high-risk AML on the basis of cytogenetics or NGS, or intermediate risk AML over 50 to receive either standard of care, DA-GO, or CPX or FLAG-IDA versus the triplet, the MD Anderson triplet of magrolimab, ven, and aza, with and then believing all these patients are going to go to transplant, and our primary endpoint is 2-year EFS. Next slide. That study is going to start recruiting in a couple of months. Where else might we improve conditioning? Well, the other area where I think there's fascinating data, again from the MD Anderson, is the triplet of aza, ven, and gilteritinib. So you can see how the triplet is applied. Next slide, please. And again, in an older, vulnerable, elderly population of patients, the striking thing about Nicholas Short's data is if you look at CR and CRI and MLFS, they're getting 100% major clinical responses. So very high response rates. The challenge, despite the high rate of MRD negativity, is still some hematological toxicity. But in my judgment, you don't need much more progress with this triplet to think about this as being the next randomized study being DA-GO versus this triplet in fit adults with FLT3 mutated AML. Next slide, please. So then that's what you might do in terms of optimizing pre-transplant induction or MRD status. Where are the conditioning regimens? Well, next slide. You'll all be familiar with the important data from the US CTN. Next slide, please. 0901 study. I'm not going to go over it because you know it. This is 272 patients who were under 65 randomized to a conventional MAC or a RIC. So the long and the short of it was RICs are much safer. Next slide. But in the first analysis, there was an increased risk of relapse. So bottom panel on your left, that is the relapse rate that conferred impaired a lower disease-free survival in patients having a RIC. Next slide, which when it was further examined, went on to with longer follow-up was a lower overall survival. And the important thing, again done by Chris Hurrigan, was to actually try to correlate using NGS performed on peripheral blood samples that were taken and banked on these patients, the impact of pre-transplant MRD. I think this is very important data. And what Chris showed was that in patients who were MRD positive, their outcome after a RIC was worse than after a MAC. So a MAC seemed to abrogate the adverse impact of MRD positivity. And in the MRD negative rate, there seemed to be equivalent outcomes between a RIC and a MAC. So this is a relatively small sample. This was a post-hoc exploratory study. And the other caveat about 0901 was that in the RIC arm, the relapse rate was really much higher than the French or the British groups have reported in prospective studies. They reported about 45, 50%. And in the MAC arm in this study, bizarrely, the relapse rate was much lower than reported in the Rambaldi study. So I think there's a few caveats about this study, but nonetheless, it does suggest to us that if you've got a patient who's fit, particularly a patient with MRD positivity, you should be thinking about a MAC. Next slide. So the other data, of course, speaks to the fundamental question, well, you've got a whole load of patients who can't have a MAC simply on the grounds of age or comorbidity. So is there any data that intensifying a RIC regimen helps? I mean, you might look at the 0901 data and say, yeah, it's a no-brainer. Use the sequential Flam-Sub-U regimen, encouraging phase 1/2 data. There's going to be an easy win here compared with Flu-Bu 2. So we did this study through the UK NCRI group, Figaro, 244 patients, as I remember, randomized to receive either the sequential arm or the, mostly it was FP2 in this study. And Sylvie Freeman did pre-transplant MRD. Next slide. So we were, I was disappointed, I have to be honest. The outcomes were just the same. I mean, they were spookily similar. No reduction in relapse risk, and even in the MRD positive patients or adverse risk karyotype, there's no benefit from this sequential regimen. It's quite a lot more toxic. People are in hospital more, and the EFS and OS were the same. Next slide. The next question is, what's the impact of pre-transplant MRD prospectively examined using flow on relapse risk? This had not previously been reported. All the MRD data was retrospective. So Sylvie did beautiful work, and she shows in this study, yes, there is an increased relapse risk, A and B, but actually the relapse risk is not quite as high as has been reported in some retrospective studies. And importantly, that means if you look at how did patients, we pooled the Flamza and the FP2 arms because the outcomes were the same. So using either one of those regimens, how would a patient who's MRD positive do? Well, yeah, they would have a higher cumulative incidence of relapse. It's doubled, goes from 20% to 40%. But actually, their 2-year overall survival is still not bad. It's 50%. So that again would speak to me to say that we should take such patients, as long as they're in morphological remission, to transplant in the absence of any data that further treatment improves outcomes. Next slide. And then finally, from this study, again, small numbers, exploratory, there was a very provocative observation that patients who achieved full donor T-cell chimerism, who were MRD positive, had a lower relapse rate. So the brown curve on the right, I don't know if you can see this, the top brown curve, that's if you're MRD positive and you have mixed T-cell chimerism, really high risk of relapse. But here, the lilac curve is if you're MRD positive and achieve full donor T-cell chimerism, much lower risk of relapse. That study is now being replicated in the next trials I'm going to show you. Next slide, please. So the next trial, which is now closed, is COSI. And this is a study where we're examining the benefit of adding thiotepa to either the myeloablative flu-bu arm, so that's a TBF myeloablative regimen for people under 55, or adding it to FP2 as a mini TBF for people over 55. So all I can say about this study is randomized 280 patients, and it's been closed by the DMC because on analysis, they do not think that we are likely to meet, by extending the recruitment, the primary endpoint, which was improved disease-free survival in the TBF arm. So it's going to be important for us to wait another 18 months for the full data set, but at least we've recruited a fair number of patients to, I think, a pivotal examination of the benefit of adding thiotepa to FP4, FP2. Next slide, please. And then finally, maintenance. It's an area that we're all fascinated by. Next slide, because, you know, oh, sorry, this is just, don't forget cord. There is a lot of data out there that people have a lower relapse rate. And this is the Seattle data, isn't it? Retrospective study. Black line MRD positive patients who got a cord, all the other lines MRD positive who got some other transplant, there's a lower relapse rate. And next slide, my colleague Rob Wynn, along with the French group, next slide, has generated lovely data supporting that. In this next study, they're hoping in children to look at expanded cords versus alternative stem cell sources in pediatric high-risk AML. I think this is a really important study, and I think we discard cord and its potential ability to reduce the risk of disease relapse in high-risk AML at our peril. Next slide. So, and again, please, next slide. So what we're thinking about here is maintenance. We know there's a powerful graft versus tumor effect. So maybe if we used a drug or even cellular therapy after a transplant, we might be able to directly target the stem progenitor population that contribute to relapse. Or alternatively, plausibly, we just delay relapse. So we buy time for a graft versus leukemia effect, allowing us to introduce DLI at a time when there's less toxicity. We did this study, actually it's the first ever study using post-transplant pharmacological maintenance when I was at the Hammersmith with post-transplant imatinib. It certainly abolishes relapse. So we wanted to look at it in the context of AML. Next slide. And keep clicking through these slides, please. So the argument here is relapse may occur before you've got GVL. So push back relapse by a therapeutic intervention and you buy time for GVL. Next slide. Alternatively, if you've got a really fantastic drug, you accelerate a GVL. And Mohammed summarized this very nicely a number of years ago in a Blood front page. Next slide. So what can we do? Well, there are two approaches, really. We go for targeted therapies as maintenance based on diagnostic mutational signatures. In other words, FLT3 mutated, you think there are going to be FLT3 clones present post-transplant, you give a FLT3 inhibitor. The alternative is you give a mutation agnostic maintenance strategy. So why might you adopt that? Well, one of the reasons you might like that approach is in this study we did with Oxford, Lynn Queck led this, we looked sequentially patients at diagnosis, NGS, patients after chemotherapy, pre-transplant NGS, and then patients at relapse. Next slide. And what we observed was a significant number of patients acquire new mutations either during intensive chemotherapy that are present pre-transplant and contribute to post-transplant relapse, those mutations not being present at diagnosis, or other patients, actually, their mutational signature stays the same. So the advantage here, if you look at the top one with, say, clonal evolution, or both of these curves on the right, you're seeing at relapse new clones, one of them P53, that weren't present at diagnosis. So if this is a common phenomenon, then using your diagnostic NGS to inform your targeted maintenance strategy may be flawed. Next slide. So what's out there? Well, I'm going to show you a little bit of data that sorafenib improves overall survival. There's two randomized studies. They're quite small, but I think they're reasonably compelling. We're waiting for the Morpho study. I don't think we should yet take a judgment on whether gilteritinib will be of benefit or not in patients allografted for FLT3 positive AML until we've seen the full analysis, which I think will be presented at EHA. So I'm an optimist that there will certainly be some subgroups. And then finally, we can use azacitidine or permutations thereof. Next slide. So this is just the nice Burkett study showing in patients who got sorafenib allografted for FLT3 positive AML, their event-free survival and their overall survival was improved. Next slide. So the questions then are, can we use azacitidine in this model? It's an interesting drug. It upregulates epigenetically silenced tumor antigens, cancer testis antigens, WT1, and also HA1 actually, which can be epigenetically silenced. So it's a good and interesting model. Next slide. And in the Amadeus trial, we have now successfully randomized 326 patients with AML and CR1 or CR2 to either receive placebo or oral azacitidine, the CC486 given 200 milligrams for 14 days. So that study closed out in March, and we are looking at a readout in 2 years' time, just under 2 years' time. Next slide. What I can tell you is that CC486 is very well tolerated, okay? So again, currently recruiting an extension of that study, adding venetoclax to sub-Q azacitidine. I think it's a really good study, and that is also recruiting rapidly, so I encourage you to open that study. Next slide, please. And then finally, just around maintenance, I want to advance to you that we need to be a little bit more sophisticated in design and maintenance studies. There's a whole bunch of patients, plausibly patients who are MRD negative or have got intermediate risk cytogenetics, whose risk of relapse is pretty low. And I'm not sure we should put them into maintenance studies, but we should be enriching for patients either on the basis of pre-transplant MRD positivity or, as Sylvie's data shows, on using also post-transplant MRD status, which is the strongest predictor for disease relapse. I think we should be enriching using MRD data and NGS data to identify a high-risk population. So bang, those are the studies that we're going to be doing. And there are a number of other candidate maintenance agents out there, as you know. Next slide. Next slide, please. And finally, and I want to make this very quick, my conclusions. So I think I've mentioned these all. I think if you're under 55, a myeloablative regimen is to be preferred unless there's good reason not to use it, and that would be fitness, but particularly in patients who are MRD positive. Older patients who are MRD positive can still achieve good post-transplant outcomes with a RIC, but we do need to think of novel strategies to reduce relapse or even better conditioning regimens. There's no evidence in my judgment that transplant should be deferred in patients who are in morphological CR1 but have detectable MRD. There's no benefit in a large randomized study of Flamza-Bu. It's an expensive, complex regimen. I don't think it should be pursued in this setting. We do need to think about how you switch people to full donor T-cell chimerism, and that may include maintenance strategies. Next slide. And really finally, just to touch on the importance of us as a community doing randomized studies in transplant. The reason we were, as a group in the UK, propelled towards this initiative was we recognize, of course, that it's a remarkably effective curative strategy, a transplant. 50% of people with incurable disease are cured, but still 50% of people die. And yet so few patients go on to randomized studies asking how to improve transplant outcomes. Next slide, please. So we set up a model, which is a transplant trial network with upfront funded research nurses in major centers and a trial delivery hub. Next slide. Next slide. And everybody said this would be the biggest failure out. We wouldn't recruit anybody. We really struggled 7 years to get funding. It was only 4 million euros, but we did get it. And within 4 years, we've randomized 1,300 patients. There's a great appetite out there by physicians and patients to enter careful, simple, well-designed randomized studies. And it also drives great science and great prospective MRD studies. Next slide. So we are now in my final slide. We have created a new delivery vehicle for UK transplant trials. And we've had to do this because the impact model was entirely dependent on philanthropy, got hit by COVID. And we're also aware, looking at models like LYSARC and the European Myeloma Network, that in fact, academic networks can deliver high quality commercial studies, and they can compete with the CRO sector in that space. So ACT is a commercial trial company. It's nimble, it has a board, it has a leadership team, and it delivers trials very quickly through funded networks. But we want to ensure that there's a Quaker principle, and so the trials that are going to be delivered by ACT are those prioritized by a matching charity, DIDACT, in which sit clinicians, research charities, patients, and also experts, international experts, in terms of identifying which trials should be delivered. We believe that this will create financially sustainable model in 4 years' time and allow us to continue to deliver practice-informing randomized transplant trials. So thank you all for your attention, and back to you, Mohammed.
Thank you very much, Charlie, and congratulations for really wonderful and fantastic achievements. We have a lot of questions, so I'll try to structure them a little bit. First series of questions is related, Charlie, to the impact of the prior transplant therapies, induction, consolidation, on the outcome after transplant. Do they really matter, or at the end of the day, as long as we are able to achieve morphologic CR or even MRD negativity, as you highlighted, it is okay? Because I guess what's behind this question is now that more and more colleagues are preaching, I would say, for non-intensive induction approaches, including in the younger population.
Yeah, well, I think it's a really perceptive question. And just as you say, Mohammed, I think Amir Fathi's study in, I think it's ECOG, which is Veneza versus CPX in allomandatory adults, is a pivotal study. Because it's entirely plausible, in my judgment, that if you're thinking about induction chemotherapy as being part of a holistic curative strategy, which includes transplant, that you really are interested in approaches that give you an equivalent CR rate, ideally better, but equivalent, but possibly less transplant toxicity. And the reason I think this is important, Mohammed, is we want to take more and more older patients to transplant. It's the most effective curative regimen. In fact, in that population, it's the only curative regimen. And using standard of induction may contribute significantly to transplant-related mortality. And also, I think with these new triplets, we should open our eyes to the fact that you may get higher CR rates than you observe with CPX or DA, and you may certainly get deeper MRD negativity. We need to do randomized studies, but I would be advancing that this is actually one of the most exciting areas of potential advance, and we're very keen to be launching the ML Act 101 study using the venasa magro versus CPX or FLAG-IDA in high-risk patients. Because I think if you look at the outcomes with intensive chemotherapy in P53 mutated patients, Mohammed, they're really awful. I mean, not only the CR rate's poor, but the toxicity is very high. So I think it's entirely plausible that actually less intensive regimens with an equivalent or better CR rate may be a game changer.
Excellent, thank you very much. Looking now to a series of questions about the conditioning regimens. You have nicely shown in the Figaro trial that actually having a sequential Flamza regimen may not be of great value. Where do you see the role of the sequential and Flamza or Flamza-like regimens? Because obviously the Figaro trial was meant for patients who were in CR, whereas the Kolb original publication was for patients who were fully blastic. So they needed some chemo to control the blastic proliferation. So in your hands, in your thoughts, where do we stand?
Yeah, well, two comments then, Mohammed. First of all, I was very excited that with the Figaro design, because I was convinced that this very smart concept developed by Hans Kolb and Christoph Schmidt, it was really smart, right? You kind of dealt with MRD and you also came in with DLI. So in Figaro, actually, Mohammed, we did include primary refractory AML. The problem was that we only recruited, I think it was 3 patients. It is actually very difficult to generate randomized data in that population. So I think there are 2 areas where it may continue to be important, either with different partners or as it's structured. One is the data in primary refractory AML is quite encouraging, Mohammed. So were it to be possible for us to do some sort of randomized study or to have a synthetic control arm, I think we should continue to pursue that. And also we should remember in the ASAP trial, it's really important initiative by Dr. Stellis. They used the sequential regimen in that study. So maybe in relapse, there is a superiority. So I wouldn't throw it out, and those are the 2 settings. But if you want my honest opinion, Mohammed, having kind of been immersed in a bath of conditioning regimens for too long, I think the important thing you do is what you do post-transplant. And I think it's what you do early post-transplant. I mean, you look at the Flu-Bu2 regimen, equivalent outcomes to what you saw with Flamza-Bu, right? And some of those were pretty high-risk karyotype. And it's around, I think, the questions should be around rapid taper of immunosuppression, should be around optimal GVHD prophylaxis. And finally, I think some form of maintenance, either whether drug or actually early intervention with some cellular product is where I'd put my money.
Fantastic. No, I think we are in agreement. We have reached a sort of a plateau now, playing with different kind of conditioning regimens, and probably we have to move forward and use the conditioning as a platform to get the graft in, and then
I think so.
Manipulate the immune system. So one question about we have a few questions about rapid decrease of immunosuppression, and you answered this. The question is whether you would use chimerism analysis as a surrogate marker for MRD in those patients where you don't have an MRD marker?
Oh my gosh, what a good question. All right, no, the answer is we need more data. And in fact, one of the things Sylvia and I are doing out of the COSI trial, Mohammed, is we're kind of having a validation cohort of chimerism and MRD with another 290 patients, okay? But I think they're two very different things, okay? I think MRD, you could do it. I think the Germans use a CD34 selected strategy, which is nice. That's an approach looking for MRD. I think you either use flow or possibly increased sensitivity NGS MRD. I think, Mohammed, the other really important point is, when do you do your post-transplant assessment of response? I think day 90 is much too late. And I think we should be moving, particularly in high-risk patients, probably to doing a marrow between day 28 and 35, and even thinking about day 60. So I think using either conventional flow, or if you've got a genetic marker like NPM1 or KMT2A, you hardly ever do use that, or thinking about pioneering approaches using NGS MRD. In those patients who are MRD positive, there should be an immediate taper of cyclosporin, and they should get DLI shortly thereafter. So I see T-cell chimerism as a manifestation of the health of the graft versus tumor effect, although remember, it's going to be GVHD prophylaxis dependent, so we can't be too simplistic. And I see measurements of measurable residual disease as entirely distinct.
Excellent, thank you very much. We have a few questions actually about AML in the elderly population. And if you have a secondary AML or a predisposing MDS and a few other unfavorable molecular genetic changes, so would MRD negativity bring these patients into like a sort of a standard risk, or they remain bad risk because they are secondary AML?
Well, it's an area. One of the good things, Mohammed, that you taught us more than anybody else about doing prospective studies is you drive really pivotal translational studies. We don't have enough good prospective integrated MRD and NGS data sets around transplant. We just don't. However, I would draw the questioner's attention to an important study from Boston that was published in Blood. I think it was about 9 months ago, and that actually, in patients over 60, suggested that NGS trumped MRD. So I think the answer is that we don't have enough robust data. You may ask me as a follow-up question, in which patients with P53 would I allograft with the P53 mutation? And I'm clear about that now. I think there's some important randomized data from a pivotal US CTN study that allogeneic transplant confers a benefit in P53 mutated. But in my judgment, in AML, that is only in patients who are in CR. I'm not sure I'm too fussed about MRD status, and it's nice if you can have it, but it's also in patients who are fit. And those patients, I think, should proceed to transplant. I think patients who are not in remission with a P53 should definitely not proceed to transplant. And you should also be very careful about making sure that the patient is fit and they can get through the transplant with an acceptable TRM. But I think there's a sizable population of inversion 3 and P53 mutated who can do quite well after transplant. And I think patient selection is key.
Okay, let's take a couple of final questions about maintenance. And actually, you nicely summarized the different available evidence. So we have a couple of questions about your thoughts on venetoclax for maintenance. I know we don't have randomized trial, but any thoughts on this? And the other question is about lenalidomide that is now becoming a generic drug to induce a GVL effect, knowing especially that we have already data about induction of GVHD with lenalidomide.
Yeah.
Early
So
after
lenalidomide's probably a bit easier, Mohammed. I think it's an interesting drug in relapse, particularly in molecular relapse. And we had a study called Viola using lenalidomide and azacitidine published, showing actually high rates of salvage, particularly in people with who are MRD positive. So it's blooming interesting, lenalidomide, because of its allo manipulatory effects in patients with relapse. The German data would suggest it's very difficult to apply lenalidomide safely as maintenance, that there is a pretty strong signal. But I'll tell you what, I think it's an interesting idea. If you were confident that you had there are two bits. When you're thinking about maintenance, Mohammed, right? You probably agree with me. I hope you do anyway. I'll be worried if you don't, because I kind of follow your thinking on most things. But one is, it has to be well tolerated, and you have to be able to introduce it early. Those are the two considerations, really. And third is, you don't want horrible drug interactions, okay? And actually, a lot of the maintenance therapies that we think about, they fall on that. So were you to do a dose-finding study of len, and you could find that at day 35, day 40, day 50, you could introduce a fixed dose, and you use that as maintenance, I think that's quite an interesting question. So I'd be there for that study. And I think venetoclax, well, the Viali-T study is hopefully going to be definitive. It's Ven and Aza. I also think it depends how you think maintenance works. The problem with the Viali-T study is venetoclax, I mean, what's it doing? The thing you don't want is something that blunts an alloreactive response, okay? And that would be the worry, is that Ven and Aza might do that. The second thing is, actually, if you look at the kinetics of MRD response in Viali-A, it's slow at producing MRD responses. Some people got it by cycle 3, but most took 6 cycles. And you might argue in the setting of AML, that's just too long. But we'll only know when we do the study, and hopefully that study is going to close out in about 9 months. So recruit away, everybody.
Fantastic. Well, it's almost 6 p.m. in Birmingham. Thank you so much, Charlie, for really an amazing, comprehensive overview about the state of the art when it comes to transplant indications in AML and how to optimize the outcome of these patients. And I think you nailed it very nicely. For the time being, this is probably, and it remains the only curative option for most of the AML patients, and we need to work hard on how to improve the outcome of these patients. And you've done some pioneering work in this field. So I'd like to thank you all for attending this webinar. Thank you, Charlie, for contributing, and wherever you are, please stay safe and keep well, and see you soon in another ICH activity. Take care.
Thank you, William Caxton II.